Hello and welcome to the third webinar in our four-part series, Educating Community Health Workers Around the Care of Key Chronic Conditions. These conditions were chosen not only because of the high or rising incidence in our communities, but also the important and unique impact that the community health worker can have as a member of the healthcare team. My name is Kathy Kunis, and I am the Training and Partner Relations staff for the Iowa Chronic Care Consortium. We are so pleased to be partnering with the Midwestern Public Health Training Center in bringing you this series and appreciate the talent of our two interns, Patrick Dowd and Molly Lee, in researching and developing the content of these presentations. Today, we are focusing on the topic of diabetes. Previously, our webinars covered opioid misuse and the topic of obesity. And we will wrap up our final episode on Monday, December 11th, with a discussion around depression. Each of these presentations will be recorded and archived, as Kate mentioned, for later review, and you will receive the links, and they're also available on the Midwestern Public Health Training Center website. So getting back to the topic of diabetes, this is not only high interest and high need, but sadly, it is a very complex condition and the incidence is increasing nationwide. The nearly epidemic proportion is attributed to both biologic characteristics and behavioral influences. 1 in 5 healthcare dollars spent are attributed to the chronic condition diabetes. And interestingly enough, 96% of the care is actually self-care. What a great opportunity for the community health worker to support the patient and family in their daily self-management. So I'd like to introduce our speaker today, Patrick Dowd. If you joined us in the first of our series on opioid misuse, you did meet Patrick and he did a fabulous job on that presentation. For those who are joining for the first time today, Patrick is a master's candidate in the University of Iowa College of Public Health, where he focuses on topics related to behavioral health and health disparities. Patrick has also worked as a direct support professional in Iowa, providing services for clients with a variety of chronic health conditions, including diabetes. Through his work with clients, Patrick became more interested in the factors that influence self-management of chronic conditions and how research can be put into practice in order to provide more personalized and effective care. And now I'd like to welcome you all and thank you, Patrick, and I will turn the presentation over to you.
All right. Thank you very much, Kathy, for that introduction. My name is Patrick, and you'll be mostly hearing my voice throughout this presentation. And I want to thank you all for your interest in this topic. I think that diabetes is an extremely important topic, and I think it's a topic that's really just only going to become more and more important as time goes on, and especially for community health workers who are providing that essential day-to-day support. I think that diabetes is something that a lot of people learn about by being put in a position where you're suddenly caring for someone who has diabetes. So whether that's a family member or a client or someone close to you. And we don't always have a chance to do our homework ahead of time. It's something that a lot of people, I think, learn on the job. So I hope that this presentation gives us a little chance to step back and learn about diabetes in a situation where we're not immediately responsible for caring for somebody or where we don't have to immediately be an expert. So I want to go over some of the goals for today's webinar. First, we should learn about what diabetes is and how it affects a person's health. And we're going to talk about health broadly, and we're going to talk about the factors that influence it both biologically and also in the environment, some of these social determinants. We're also going to talk about social factors that impact individuals living with diabetes. So once people have the illness, what are the factors that affect self-management of care? And we're going to want to know the crucial activities that are involved in diabetes self-management. And finally, we're going to try to feel empowered to assist clients to make healthy decisions that will improve their ability to self-manage their diabetes according to their abilities. Now, before delving into what diabetes is and how it works, I think it's first good to know a little bit more about insulin and how it functions for a person who doesn't have diabetes. So when food is consumed and digested, parts of it are broken down into a type of sugar called glucose. And when glucose is released into a person's blood, it signals the pancreas to release a hormone you've probably heard of called insulin. Insulin then allows cells in the body to absorb glucose and use it as the main source of energy to keep us going. So when this system is functioning properly, which we can see in this figure over here, that's just going to kind of keep going, when the system is functioning properly, the amount of glucose in the person's blood stays at a healthy level, and insulin signals the liver to store extra glucose that is not needed for energy. But we see this smooth process of sort of the insulin communicating with the cell to kind of unlock and allow the glucose in. When a person has diabetes, this process in which insulin allows glucose to be used by cells is interrupted for one of several reasons. So diabetes is defined by problems with insulin, but exactly what those problems are depend on the kind of diabetes that someone has. So in type 1 diabetes, which we see in this slide, the body either does not produce any insulin or it doesn't produce a sufficient amount to regulate blood glucose levels. And just as a little aside, when someone has type 1 diabetes, oftentimes it's talked about as if they don't produce any insulin. But research actually shows that about a third of people with type 1 diabetes do produce insulin, just not a sufficient amount to regulate their blood sugar levels. And this lack of insulin, it causes a number of problems. First off, glucose is that essential source of fuel for your body. So when the body's cells can't utilize glucose, it can't really operate. In several cases, it can begin burning other fats in the body for energy, and that leads to some other complications that we're going to talk about going forward. But on top of that, since the body's cells aren't burning that glucose, it remains in the blood in high concentrations, which has other health problems associated with it. Now, type 2 diabetes is what we're going to be primarily focusing on throughout this presentation. And there are a couple of key differences between type 1 and type 2 diabetes. For one, the majority of people with type 2 diabetes do produce insulin. So one of the problems is that the body cannot use the insulin properly that it does produce because they become insulin resistant. So looking at this picture on the right, the process looks actually pretty similar to what we saw in the first slide of someone who typically has the insulin communicating with the cells to open up. So we see this kind of typical process, but at the very last step, the cells don't actually open up and accept the glucose. So even though this is sort of a different process than type 1 diabetes, type 2 diabetes still has this effect of this buildup of glucose in the blood. Another one of the differences is that it doesn't typically require insulin injections because the body is producing some insulin. So usually it requires more lifestyle factors. So things like changing your diet and changing your exercise behaviors to manage diabetes instead of having insulin injected. Another reason that it's a little bit different than type 1 diabetes is that it's often diagnosed later in life, type 2 diabetes. So type 1 is typically, when we hear about juvenile diabetes diagnosed early in life, we're usually talking about type 1 diabetes. And as a result of this being different, type 2 diabetes is sort of a combination of biological, environmental, and behavioral factors. So it is diagnosed more commonly in middle age and older adults. So it's worth noting that we're seeing more and more cases of children with high blood glucose levels and more children actually being diagnosed with type 2 diabetes, but typically the most common age groups are still that middle age and older adults. And listed here are a few of the lifestyle factors and the main risk factors for type 2 diabetes. So we can see some like obesity it's often talked about as sort of a twin epidemic, type 2 diabetes and obesity. About 90%, maybe 85%, according to some estimates, of people with type 2 diabetes are classified as either overweight or obese. But that means there's still 10 to 15% of people who aren't overweight who have diabetes. So it's by no means a one-to-one equivalent of obesity and type 2 diabetes. Another risk factor is sedentary lifestyle, this lack of exercise. Even among people who are overweight, having sort of rigorous physical activity or really any physical activity at all is more of a protective factor against diabetes. We also have family history of diabetes, which is really important. Oftentimes people who do have diabetes will also have a family member, and part of that is due to sort of shared environment, but a lot of it is also genetic. We also have a history of gestational diabetes. So that refers to women who develop hyperglycemia or high blood sugar. So they develop diabetes while they're pregnant. Then not only will they have a higher chance of developing type 2 diabetes later in life, also the children will as well. And also race or ethnicity. We have these really big disparities between racial and ethnic groups. on who has diabetes. And again, a lot of that is due to social environmental factors. The actual genetic aspects of that aren't understood quite as well, although there's a lot of research still going into that. But right now, we talk about sort of these differences in social environment. So we've talked a little bit so far about the biological mechanisms and risk factors underlying diabetes and how those work, but that doesn't necessarily tell us how diabetes affects someone day to day. So if we're looking at this picture on the left, we've already talked about people struggling with high blood glucose, which is also called hyperglycemia. But when blood sugar is high and the body can't lower it by using some of it for energy, it's going to try to remove it in some other way, which can result in a bunch of sort of uncomfortable and really debilitating symptoms for people. So on the right in this figure, we see a chart. We see symptoms like frequent urination as the body tries to flush out high glucose levels. We can subsequently see dry mouth and increased thirst as people become dehydrated. We see headache and blurred vision. Some of these symptoms that are sort of described as being in a fog a little bit. And in addition to the high blood sugar that we see with the hyperglycemia, a number of people with diabetes also experience hypoglycemia, which is chronically low blood sugar. And that's especially common with people who are taking insulin, because if they then eat a little bit less than they expect to or that their body's used to, and they're still taking the normal amount of insulin, then their blood sugar can suddenly become very low. And that causes a bunch of other effects, things like sweating or hunger, and general confusion and sleepiness as well. So we have both these effects sort of happening at once. So in addition to those symptoms, extremely high or low blood sugar can lead to a loss of consciousness or diabetic coma. And those are really emergency life-threatening situations that need to be addressed using medical care. It can't be self-managed. So if it gets to that point, it's important to seek out medical attention. And that's more common in type 1 diabetes than type 2 diabetes, but anyone with diabetes can suffer from diabetic coma. And other illnesses like cold or flu can also affect people with diabetes by boosting their blood sugar. So flu, for instance, it does actually boost blood glucose levels when someone has the flu, or something like pneumonia, which people are more likely to be hospitalized if they get pneumonia when they're diabetic. And in addition to those day-to-day factors, we have these long-term factors. So long-term, high blood glucose levels can have a variety of complications. High blood glucose damages blood vessels and nerves in the body, and these effects really become more pronounced over time for people who have had diabetes for a number of years, oftentimes. So one of those effects is an increased risk of heart attack or stroke or heart disease in general. And that's also increased by other risk factors such as smoking or obesity or high blood pressure or high cholesterol. But those things need to be especially carefully monitored in people with diabetes. It's estimated that people with diabetes are at least twice as likely to develop heart disease at a young age if that diabetes is uncontrolled. Additionally, we have diabetic neuropathy, which is nerve damage over time. And this risk really increases with the number of years that someone has had diabetes. Nerve damage, it often affects extremities, so thinking about toes and feet and hands, but can also lead to problems with internal systems like the digestive tract or the urinary tract. And people with diabetes can go on to develop sores as well, sores and ulcers on their feet. And these sores, if they become common, they can be very difficult to treat and they can become infected. They're actually a leading cause of amputation for people with diabetes, is those sores, as well as the neuropathy. And damage to blood vessels in the retina presents a risk for blindness. Diabetes is right now one of the leading causes of blindness as well. And finally, we have kidney damage, which damage to blood vessels in the kidney, which can happen actually quite quickly or over time. So again, these pretty severe long-term complications of diabetes as the illness progresses. So we've talked about type 1 and type 2 diabetes, but a large portion of the population also experiences prediabetes. And the majority of those individuals, and I would say the vast majority, are not diagnosed. But prediabetes occurs when people have consistently high blood glucose readings, but not high enough to meet the criteria for a diagnosis of type 2 diabetes. So we can see over here on the right, the sort of diagnostic criteria for various types of diabetes, including prediabetes. And I just want to quickly go over what each of those means. So we have first over here, hemoglobin A1C tests. And those are blood tests that measure average blood glucose levels over the period of a couple months, so more long term. Then we have the fasting levels in the middle here, which is after not eating, and then for probably close to 7 or 8 hours, then they measure people's baseline blood glucose. And finally, this last one is a couple hours after eating. So this one will typically be the highest. It's after a meal. But importantly, people with prediabetes go on to develop type 2 diabetes at a pretty alarming rate. So we see 70% of people with prediabetes go on to develop type 2 diabetes. And that's quite important because about a third of the population has prediabetes. So if we have a 70% rate going on to develop type 2, then that really is a pretty alarming statistic. Another thing that's worth noting, though, is that there are actions that can be taken. There are actions that can be taken when someone has prediabetes to lower the risk of going on to develop type 2 diabetes. So people who lose 5 to 10% of their body weight have been shown to significantly lower their chance of developing diabetes, even when they've reached that pre-diabetes level already. And to place this in kind of a larger context, rates of diabetes have really exploded since the 1990s. We talked about this a little bit in the introduction. But in the United States, we can see this high proportion of people who have prediabetes and then who later go on to develop type 2 diabetes. Now, nearly 10% of Americans have type 2 diabetes, any kind of diabetes, with this rate varying pretty widely from state to state. But it's also the 7th leading cause of death in the United States. And some researchers believe that this could actually be underestimated. And the reason that it could be underestimated potentially would be by not recognizing, say, if someone had heart disease, not recognizing that it was attributed to that diabetes, and maybe not including that in the cause of death. So it could be even more drastic than it looks from those statistics. The rate of diabetes, again, among older adults is really something to keep an eye on, because adults over 65, we see that about a quarter of them have diabetes. So they are the most at-risk group of all. And then we also, again, have these racial ethnic disparities. So about 13% of African Americans, about 12% of Hispanics, we see that higher rate than among white people in the United States. And a little closer to home, the diabetes epidemic is certainly present in the state of Iowa. So Iowa had a slightly higher rate of diabetes than the national average, and really that at the bottom here, this 84% increase between 1991 and 2009, that really stands out to show just how much it's increased over time and how much it's continuing to increase. So diabetes, we see on this map a little bit, some counties and states in the Deep South have probably some of the highest rates of all. Iowa is a little bit closer to the average rate, but still slightly above, and definitely an area of concern in Iowa. So when a client has diabetes, it's important to become acquainted with some of the key appointments and healthcare team members that are needed to manage that. So managing diabetes is already really stressful. It already carries a lot of stresses for the person who has the illness. And helping someone navigate this complex system can really lift some of that burden and make it a little bit easier to manage. So the most important member of this team is right at the top here, that primary care provider. And typically they'll outline the course of care for a patient and then direct them to other services as necessary. And a lot of those referrals might be just for a specialized checkup here and there, or to make sure that a person's self-management plan is going as expected. But there are other times when they'll want to see a specialist because there are particular problems with the course of care or things that aren't going as expected. So again, we have sort of these periodic checkups, and it'll vary whether these can be performed by a primary care provider or whether these require a specialist. We have things like an annual eye exam, which sometimes can be done by the person's physician, and sometimes they'll need to go see an optometrist, or an annual foot assessment, but they might be directed to a podiatrist if they're experiencing these sort of these ulcers that are sort of resistant to the initial care, and they might need to be prescribed a particular ointment or a particular pair of diabetic shoes. So if a person's experiencing some numbness in their feet too, these sores begin to appear on their feet, a visit to the podiatrist is probably a good idea. And we also have endocrinologists up there. Potentially, if a person is maybe the level of insulin that they've been taking for a long time is suddenly not working anymore and they want to get it just right, then a visit to an endocrinologist who's a specialist in hormones and who knows about the endocrine system could be and something that the primary care provider would recommend. Now, all those medical staff are helpful to know, especially when someone is really struggling with the effects of diabetes. But I want to stress again that the most important activities for managing diabetes, they don't occur in the hospital. They occur out in the person's home or in the person's life, and they're the things that the person's doing themselves. So as Kathy sort of mentioned in the introduction, about 96% of the care that goes into managing a person's diabetes is done by that person themselves, or it's self-care. So self-management of diabetes is really the key factor for determining how the illness progresses. So when we look at outcomes for diabetes, people who are avoiding those long-term health problems like heart disease or nerve damage or amputations, they're the people who are successfully managing their diabetes at home through health-promoting behaviors. But self-management is an enormous job. There are a few activities that are especially important and that we're going to pay particular attention to. So here we have planning and maintaining a healthy diet, exercising regularly, monitoring blood glucose, and taking medications as prescribed. And we're going to go into a little bit of depth on each of those as we go forward. But before we do, I just want to talk about these social determinants of health. Because what we unfortunately know is that all those activities, they're not easy. And someone might say, well, if eating vegetables or exercising a little bit more could potentially save your life, why wouldn't you do that? But I really like this quote at the top here. It says, type 2 diabetes is part of a cyclical process. It both results from and contributes to adverse outcomes. So our behaviors are always interacting with our environment. This is especially true in the case of diabetes. We sometimes have perhaps a little bit more of a narrow view of what factors impact our health. But if we're looking at this figure on the right, it paints a much broader picture and looks at the different levels of influences, really sort of digs into those social factors that influence our health. And we see those personal and behavioral factors sort of right in the center at the beginning, and those are quite important. But also we have things like community factors, like a person's education, the food that they have access to, all those factors, which are also essential to look at when we're talking about people's diabetes. And those really comprise a lot of the barriers that people face, and they also comprise a lot of the supports that might help them manage their diabetes. This chart is a little bit confusing. I debated putting it in or not because I actually have some questions about it as well. But really what I got out of it was that it sort of shows where healthcare has stumbled a little bit in addressing diabetes. Despite these social determinants playing really just like such a central role in determining outcomes for people with diabetes, the way the society has tried to address the problem has focused definitely more on the biological responses to the environment rather than the environment itself. So what this chart illustrates is that health professionals, they often try to intervene at points where people are already struggling, or they're already having trouble in their present environment, or they've already adapted these sort of unhealthy behaviors as a very logical way of living in their present environment. So obviously we can't magically change all environments. We can't lift all of our clients out of poverty. And of course, we can't magically fix diabetes, but it is very valuable to keep those factors in mind so that we can work to reduce the impact that they have on health, and we'll delve further into that throughout this. And just to show the way that some of this plays out, diabetes is not distributed equally in the population at all. People who are racial and ethnic minorities are more likely to have diabetes, and the majority of those differences are accounted for by looking at the fact that those people belonging in those groups are more likely to live in neighborhoods with material deprivation or due to historical discrimination. And the low-income group really stands out in this chart with over 6 times the chance of getting diabetes than high-income groups. So this is pretty remarkable and shows that sort of by and large, poor people are not having access to the resources that they need to stay healthy. And that probably doesn't come as much of a surprise for those of us who work with folks living in poverty or those of us with personal experiences. But diabetes is one of the issues that really highlights these enormous health disparities that persist in our communities. And one of those major social factors is built environment and access to nutritional food. So looking at it, this top issue is food deserts, which is talked about so often with diabetes. And it's talked about often for a reason. In communities where there's nowhere to buy healthy food, it can be really hard to eat healthy. And a lot of communities with food deserts have lots of corner stores or have lots of convenience stores where people can pick up food. So a food desert isn't necessarily a place with nowhere to buy food at all. But really, most of those options are going to be sugary, processed foods, which aren't dense in nutrients. So the conversation's actually been switching a little bit. They've been talking about a little bit less about food deserts and a little bit more about food swamps. So these areas that are really saturated with places to eat that are unhealthy. Additionally, and something that's we've seen increase along with the diabetes sort of increasing in the last 20, 30 years is urban sprawl. And so as cities are sort of built in a way that's not conducive to walking around and walking to destinations or walking to the grocery store, instead people are commuting a long time to get to work. We're seeing this sort of increase in diabetes as well as obesity goes up because people are living more sedentary lifestyles as they have to commute via car all the time. And for people who do want to exercise, neighborhood safety is a huge issue. So if you're in a neighborhood that isn't safe to go outside or you don't feel like it's safe to go outside, then you're unlikely to really exercise in that community. And then if you don't have transportation to another place where you do feel safe to exercise, then it's unlikely that you're going to engage in that behavior. So there are all these built environment factors that really contribute to people living more sedentary lives now and also consuming less healthy foods and foods that really lead towards diabetes. And economic factors play maybe the most important role in socially determining diabetes and diabetes self-management. And I would refer back to that sort of 6 times higher rate for low-income groups that we saw a couple slides back. People who are experiencing economic instability, they're more likely to have a harder time developing a clear routine and they can stick to in order to manage their diabetes. So food insecurity is one way that this is clearly demonstrated. If you aren't sure what your next meal is going to be or where it's going to be coming from, you aren't really thinking necessarily about how that food will affect your blood glucose levels. So when you have the opportunity to eat, you might choose something that's low cost and very dense in calories because you're not sure when your next meal is going to be and you just want to fill up on something. And this gets into something called the hunger binging style, which is common for people who are food insecure. And it really consists of sort of eating a lot when you have the opportunity and then going through long periods without eating much at all. And that can really place you at a high risk, especially for people who have diabetes. That's really the opposite of what you would want to do for maintaining your blood glucose levels at a stable rate. And so really there's a difficulty maintaining for people who have diabetes and who are food insecure. And they're definitely a priority group. Also, there are problems paying for medications. We've talked only a little bit about this, that oftentimes people do need medications to manage their blood glucose levels. So a pharmacist will be a key part of their healthcare team. And if they can't necessarily pay for medications, then it can be a real struggle to maintain their blood glucose levels. And that can kind of then lead them to think, well, why bother trying to maintain if the medicine that I need isn't here? Additionally, we have housing factors and utilities. People who live in homes that are more deprived and homes that are of lower quality usually have higher rates of diabetes, even compared to people with similar income groups. So that's been something that people have been investigating recently. And then finally, just that uncertainty and stress that comes from being impoverished, living in poverty. If you're uncertain about where your next meal is coming from, like I mentioned, then it is really hard to plan ahead and sort of decide, okay, this is going to be my daily routine now. There's so much stress going on, both with managing and with being poor. And those things sort of in conjunction with one another can have sort of this doubling effect. And finally, we have these cultural factors. So in addition to the more concrete environmental factors, everyone lives within a cultural context of what is normal. And this often is instilled in us when we were very young, and we carry a lot of those perceptions with us throughout our lives. So one criticism of health education is that that's available to people with diabetes, or for people who are at risk for developing diabetes, is that it fails to take culture fully into account. This can play out in really obvious ways, like, say, having a language barrier. But there are also some more subtle ways that we can ignore culture. So if you ask someone to start adhering to a diet without considering the significance of food in their life or food in their culture, or the kinds of foods that are accepted amongst their friends, it's really unlikely that you're going to see a change right away. And this is especially important because we know that many cultures have unhealthy foods as sort of central parts. So I think that you can walk around even, they say, the Iowa State Fair and sort of see how unhealthy foods play an important role in Iowa's culture. in the way that's sort of difficult to avoid. So even when people have a behavior that's having a negative impact on their health, it's important to have those discussions about what their behavior means to them and to not mistakenly sort of criticize an entire culture when you're trying to just change a single behavior, or to encourage a single behavior change. So one common cultural barrier in diabetes is the perception that we also need to be perfectly self-reliant and that asking for help is sort of a character flaw. So I think getting around that and sort of learning to collaborate on diabetes and help people realize that they don't have to do it alone is also critical. I think that all of those social determinants that we've reviewed, they can really sort of illustrate why people have a hard time managing their diabetes. But it's important to remember that millions of people actually do manage their diabetes successfully, and that there are steps that we can take to reduce those barriers and help people as they strive towards this goal. And I think community health workers can be just an amazing resource in that position, especially because they can have an impact on a person's life outside of the hospital. So sort of the day-to-day routine factors. And there are a few ways that I think that they can be particularly effective. One of those that the research shows is sort of acting as a bridge between clients and medical personnel. One of those is sort of monitoring symptoms. One is helping the client create and carry out goals related to diabetes self-management. And finally, we have just providing emotional support. Before we talk a little bit more about those, I first want to show a brief video. It's by no means a perfect representation of what interactions with clients might look like, and it's definitely simplified for the purpose of a short video, but I want to show it anyway because I think that there are some key takeaways that can be applied in order to sort of talk about what shared decision-making can look like. I'm just going to skip right ahead a little bit to go to this part right here.
Let's start with behavior change. For years, health professionals have demanded that patients eat better and exercise by scaring patients or begging patients to make those changes. That rarely works. Healthy behavior change requires making an agreement between caregiver and patient, and we call that agreement an action plan. Let's look at the first interaction between Victoria, the community health worker, and Senora Romero, who is a patient with diabetes.
Senora Romero, I'd like to show you this chart of your hemoglobin A1C.
Okay.
It looks like your hemoglobin A1C is about a 10. You should be about a 7. So you have to bring it down from 10 to a 7.
Okay.
So this means you're going to have to increase your exercise, eat a little bit healthier, and you probably have to take an extra pill prescribed by your doctor.
Okay.
So put this graph on your refrigerator, and that should keep you motivated.
Sure.
What just happened? Victoria has no idea if Senora Romero understands or agrees with what has been said. It is doubtful that Senora Romero will do any of the things that Victoria recommended. In this dialogue, Victoria tells Senora Romero what to do and never asks what she thinks. Let's try it again.
I would like to show you a graph of your hemoglobin A1C. Is that okay?
Okay.
Has anybody ever explained to you what this graph is about?
I've never seen it before.
Okay, do you know what a hemoglobin A1C is?
No.
Okay, so hemoglobin A1C is a blood test, which gives us another way to measure how well your sugar is doing. This is a graph that measures your sugar over time. This red line right here is your hemoglobin A1C. This is where you should be. You want your sugars to be 7 or below. So 3 months ago, you were at goal at 7, but now you're at a 10, which is pretty high. Does that make sense?
Yeah, so you're saying that I need to be at a 7 where I used to be, but now I'm almost at a 10?
That's right. What do you think about that?
Well, I don't like it. I want my number to be back to a 7.
Okay. Is there anything that you feel that you can do to bring your hemoglobin A1C down to a 7?
I don't know.
It's okay. You have different options. Here's an action plan that we use for our patients here at this clinic. You can improve your food choices by eating healthier. You can increase your physical activity. You can take your medications regularly. Is there something that you are willing to work on?
I'd like to work on improving my food choices.
Okay, maybe we can do an action plan around improving your food choices. Do you think there's something that you eat that causes your sugar to go up?
Well, I do eat 5 tortillas with every meal. Do you think that brings my blood sugar up?
Yes, it does. Do you think you can work on cutting down the amount of tortillas you eat?
Yeah, I'll cut them out totally.
Okay, that's good. But let's do a reality check. I just want to see how sure are you that you can stop eating your tortillas altogether. This is the scale we use to measure how sure you are. 1 means you're not so sure. 10 means you're very sure. Where do you think you lie in this scale?
I'm about it too. I don't think I could give up my tortillas.
It's okay. We'll take it step by step. Is there anything you can do about your tortillas that you feel that you can succeed at?
I could eat 3 tortillas instead of 5. I'm 100% sure I could do that.
So that can be your action plan. When do you want to start?
Tomorrow. I need to get my A1C thingy down to 7 again.
Do you think that there's a place in your house that you can put this graph to motivate you, to inspire you to bring hemoglobin A1C down?
I'll put it in my kitchen.
Okay, great. Is it okay if I call you in a couple of days to see how you're doing with your action plan?
Yes, please.
Okay.
Thank you.
So some takeaways from that video. First of all, it's clearly they have a client who sort of easily identified maybe a problem in their own behavior and also who was very motivated to change. So I think people who work as community health workers might realize that that's not always the case. You won't always have necessarily someone who right away is ready to go like that. But I think there are some key takeaways. So one is that just telling isn't enough. Just sort of saying this is what's going on and this is what you need to change isn't sufficient for creating sort of lasting behavior changes. Additionally, seeking input from the client whenever possible. That is just absolutely important. Exploring a variety of options. So in the video, sort of, they have an action plan with a few different options, whether it's exercising or changing up the diet, not really sticking to one thing and saying, okay, this is what you need to change. And finally, working to come to an agreement on specific and attainable goals. And I think that's sort of the fundamental takeaway of the video, is that an agreement is more likely to produce change than just a direction. Now, a common experience that I think lots of clients have is that they experience things that they bother them during the week or during the month or during an entire year. And then when an appointment rolls around, they don't necessarily remember all of those things. And so I think a community health worker, one of the ways that they can help is by acting as a bridge between healthcare workers and the clients. So sometimes information delivered by healthcare professionals can be difficult to understand or apply. So community health workers can both take note of things and also they can make it a little bit more relevant to a person's life. And similarly, it can be difficult to express a number of concerns during a short appointment. So sort of taking note of those things and reminding the client and prompting the client, okay, an appointment is coming up. Is there anything that you want to note? And I have a couple examples of that here, of sort of the way that acting like a bridge can look like. And so one is planning questions. So we might have a community health worker say, okay, your appointment with your doctor is on Tuesday. Are there any questions that you might want to ask her about? The client saying, I'll probably just listen to what the doctor has to say. The community health worker saying, okay, that's good. But I remember your feet were bothering you the other day. Maybe you want to ask about diabetic shoes that might help you be more comfortable. So taking note of those little things and helping to plan out an agenda before going into the hospital can make it a lot more productive in those short visits with personnel. Additionally, making information more accessible. So a client might have a doctor tell them that their blood glucose is too high and that you eat too many empty carbs. But that might not have a whole lot of meaning for the client. So saying, I know you've been working hard to stick with your meal plan. Do you think there's anything you want to change in your diet? Client could say, no, I ate plain chicken and rice 3 times last week. I don't need to change anything. And then sort of saying, chicken's a great choice, but white rice can actually raise your levels. Maybe try another side you enjoy, like collard greens. So sort of taking that information that comes from a primary care provider or a specialist and attaching the meaning to the client's life from the things that you see every day working with them. And periodic checkups, they really identify these noticeable changes. But most of monitoring for diabetes is day-to-day. So one parameter of monitoring is blood glucose. And there are a few ways that community health workers can help monitor blood glucose. One is just to know the physician's instructions for how frequently blood glucose should be checked and prompting the client to stick with those goals. But I think just as importantly, or if not more important, is to making sure that the client, that it has meaning for them when they are checking it and that they're seeing, okay, this is my normal range and this is potentially above my range, this is below my range, and then promoting sort of independent checking as time goes on. And making sure that the client has the necessary equipment to check their blood glucose, so making sure that their meter has all the materials that they need. And also having an action plan for when blood glucose is dangerously high or low. Anyone who's working with a client with diabetes should have a plan for what should happen if it gets below or above a certain level. Know where, okay, am I going to the emergency room when it reaches this level? Do I have all the health information available to take with me to the emergency room if I need to transport a client? Also, we have checking up for neuropathy and diabetic neuropathy, the nerve damage that we talked about earlier. Talking to clients about numbness or tingling and burning and sharp pains. That's a really important way that we can help monitor symptoms. Weight gain is intuitive because we've talked a lot about the relationship between obesity and diabetes, but also weight loss is something that you might not think about so much with diabetes because it's something that we're also oftentimes trying to promote, is sort of this moderate weight loss, but really, really quick weight loss can be a sign that there are problems with the balance of insulin and that they're burning other fats that they shouldn't be burning necessarily because they're not able to use glucose. Also, medication side effects. So if you have a client who's taking medication, it can be really hard to sort of parse out the effects of the diabetes from the possible side effects of the medication. And it's really important not to ignore when a client says, okay, since I started taking this med, I started experiencing this symptom. Even if it's a symptom similar to something that they might experience with diabetes, checking in with the provider to make sure that it isn't a side effect that could provide a lot of discomfort is really important. Finally, we just have foot care, so making sure the client is checking their feet for spots and swelling daily. About 15% of people with diabetes wind up getting ulcers on their feet, and so really monitoring is a good way to see if your client is perhaps going to be one of those people who needs to have a regular foot exam, or whether they need to get special ointment or shoes. And in addition to sort of monitoring the overall health outcomes and looking at those aspects like blood glucose or neuropathy, we can also monitor and encourage certain behaviors. And that sort of, we talked about that in the video a little bit. But this really begins with setting goals. So these goals should be driven by informed decisions made by the client that are consistent with their own priorities and hopes for the future. So the role of community health workers can be to really reduce the social barriers to pursuing these goals rather than just setting those goals themselves. So for instance, if a person sets a goal that they want to exercise more often, finding a safe and comfortable space to exercise could be a great way that a community health worker could assist on that. Or providing a weekly menu planner, printing that out every week and giving it to the client so that they can plan their meals out over time. That's another way that a community health worker can really help out as a member of the team. One of the most important roles for a community health worker is to provide emotional support to clients with diabetes. So diabetes can affect a person's mood and also is associated with higher rates of clinical depression. So diabetes and depression, it's a relationship that's not fully understood, partially because diabetes and depression can both cause some similar symptoms in terms of lack of energy. It's a little bit hard to distinguish which is responsible, but there's certainly this relationship that we want to monitor for and be careful that we're taking mental health concerns, especially seriously for people with diabetes. But diabetes itself, even in the absence of clinical depression, it's very stressful. So there's concern over complications, there's feeling responsible for undesirable results. And this, especially because there's sort of this immediate accountability if someone checks your blood glucose and you feel like it's your fault if it's high, and then feeling fatigued from constantly having to manage the diabetes. So there's really burnout and stress in addition to that depression. And one thing that I want to mention is just the sort of remaining, not getting frustrated by relapse. Oftentimes we sort of talk about high relapse rates with people with alcoholism or drug addiction. But one statistic that I saw that I thought was particularly interesting was people with diabetes have actually just as high a rate of relapse as those groups. When I talk about relapse, I'm talking more about being in a